Hi, good evening, Dr. Asha.
Namaskar,
evening, ma'am.
ma'am. I'm
Hi.
making it live now.
Okay.
Making it live.
Madam, it is out as well.
Namaste, Revati, ma'am.
Namaste.
Welcome,
Hi,
Dr.
Dr.
Ritu.
Asha. Hi, Revati madam, good evening.
Hi,
I'm
good
Radha ma'am.
evening.
Shikala madam, good evening.
Good evening, everybody.
So it's 5 o'clock and all our guests are here. Namaskar. I welcome you all to this 34th edition of Searchlight. Today, the Searchlight is on updates on LSCS. We are doing it with Jalandhar, Garhinglat, Sirsa, Vijayanagara, and Raipur Gynec Societies, and we have guests from all over. So, before we start the program, we take the blessings of the divine. I wish all of you to please join me for prayers.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतङ्गमय ॐ शान्ति
Namaskar. Now, I would like to introduce my conveners, Dr. Sujayshri Sangeeta, who's the Secretary of Bhimavaram Obstetric Gynec Society, and Dr. Purvi Agrawal, the Executive Member of Society of Fetal Medicine, Raipur. So, Dr. Sujayshri is a consultant obstetrician, gynecologist, and lab surgeon having 2 hospitals in Palakol and Malkapuram. And she has a lot of awards and papers, and her interest is in laparoscopy and fertility. We have Dr. Purvi Agrawal. She is a very active fetal medicine specialist from Raipur. She is IOTA and FMF certified, and she is a trainer for Foxy in the ultrasound training program. That's me.
Good evening, everyone. I would take this opportunity to introduce our program coordinator and mentor, Dr. Asha Jan ma'am. Ma'am is Director SMSA Hospital, Medical Director of Cancer Prevention and Relief Society. She has been Chairman Mission Pink Health IMA Raipur, Executive Member of various societies, past President Raipur Obs Gynae Society, has multiple interests, multiple publication. She has been recognized Center for Foxy for ultrasound training and colposcopic training. A very warm welcome, ma'am.
Thank you, Purvi. Thank you so much. Now, I request everyone, today we have the chairperson of Food Drug Committee with us as our guest of honor, Dr. Ritu Khanna ma'am, requesting blessings from everyone. And Nandita ma'am is yet to join, so I would introduce our guests of honor first. We have respected Revati Jankiram ma'am with us. So she was VP Foxy, South Zone, and she's a founder secretary and past president of Madurai Gynec Society, founder president Madurai Menopause Society, zonal coordinator, Foxy ACS HPV vaccine drive, She has the Dr. Durusha Community Services Award, Lifetime Achievement Award, and selected as a master trainer for PPIUCD program by Figo Foxy, has written many chapters in Foxy Focus, UG and PG books, and has the Pride of Foxy Award in November 2019 at Mumbai. Welcome, ma'am. Today, our
Thanks.
spotlight is on LSCS, requesting you to say a few words.
Thank you. Thank you, Dr. Asha, for your kind words and also for your kind invite. I am really surprised to note that such a huge number in this Searchlight series, that 34th webinar you are conducting. I appreciate your great effort. And today's topic is really a needed one for today. Thing is that LSCS, the present generation actually, they don't do section on indication. Instead, they find to justify their cesarean section by making an indication. So that they have to be very, very careful. And of course, our speaker, Dr. Ramani, is going to talk about this ideal C-section. And most of the thing is that the difficulties during cesarean section, we have to anticipate, identify, and tackle it meticulously to avoid not only morbidity and mortality of the mother, but also from litigation problems. And definitely we have to know about all these things, especially the younger generation. And I'm sure this webinar is going to give throw some light on that and give a lot of take-home message for them. And thank you very much for inviting me here. I wish this webinar a grand success. And I also extend my best wishes to Dr. Asha for success in the future election and to become chair of Food and Committee Foxy. Thank you very much.
Thank you so much, ma'am. We are really grateful to have you here. And today in our panel, we have all young doctors. We really have very young doctors. They are just pass outs or young practitioners from AIMS Raipur. So let us see how they take this webinar forward, because today they are the main part of this webinar after our speakers. So, and obviously we have great speakers. So now I would like to welcome Anuradha Khanna ma'am. She has so kindly agreed to join in as a guest of honor. She is an ex-HOD, Department of Gynae, BHU Varanasi. She is the President UP Chapter of Obstetric Gynae, Founder President Society of Fetal Medicine UP, ex-President WOGS, and Founder President Varanasi Menopause Society, has organized n number of events, has been in the GCM of ICOG and Indian Menopause Society. She is an MD, MBBS examiner and DNB MCI inspector. She has many awards and fellowships, and we are grateful to have you here with us, ma'am, requesting you for your words of wisdom.
Thank you very much, Dr. Asha. I really appreciate your hard work from core of my heart. You are so much vigilant of all the subjects. You are trying your best to make all the doctors aware of so many good things, a good practice, and also facing different problems which we are having in our practice with academic knowledge. That's a great effort of you. And I wish you a very nice to be elected as a chairperson of Food and Drugs after Ritu Khanna. Ritu Khanna is also very close to my heart. And after that, I'm sure you are going to be the chairperson of this. And regarding cesarean sections, as Dr. Revti has already mentioned, that we are justifying our LSCS, why we are getting it done. Previously, the prevalence was very low, but because of the rising medico-legal problems and much awareness, much CTG, much ultrasound, and going in depth of high obstetrical reasons to get cesarean section done, because we don't want to leave even a single child dying of anything, whether it is a mental or handicapped or whatever it is. So many indications. That's why the rise of induction of cesarean sections are there. This is one thing. And then there are so many techniques which have come one layer, two layer, single layer, double layer, and where to get it done, what is the scar we have to like to put, how much suprapubic incision, and how much about the putting the incision over the lower segment. What is lower segment? How much should we have to go very below? If you go very below, what are the advantages and disadvantages? Previous LSCS and so many problems of equine feta going to become as a syndrome for repeated cesarean, rise of cesarean. So we, and also the baby has not been learned how to live in difficulty without labor. No fluid inside, outside. So that is a very not good factor for the fetus also. The head compression, the chest compression, the inspiration, and so many things I'm going to listen. So I will not come in between you and academics. So all my best wishes to all of you, especially Dr. Asha to be elected as a chairperson. Thank you very much for inviting me over here.
Thank you so much, ma'am, for those words of wisdom. We are really happy to have you here, and I hope your blessings will take me across. We have Ritu ma'am with us now. Welcome, Dr. Ritu. Ma'am is the director of Khanna Medical Center Fertility Clinic. She is a fertility specialist and endoscopic surgeon, a really very sweet and happy and ever smiling person for us. She is the chairperson for Food, Drug and Medical Surgical Equipment Committee, National VP Indian Fertility Society, Secretary Society of Fetal Medicine UP Chapter, Central Executive Committee member SFM 2024-26, Executive member UPCOG, VP WOGS, Secretary WOGS in the past, and Organizing Secretary of Fertivision, UPCOG, and just now a very wonderful conference in Dehradun for the Food Drug Committee. Her areas of interest obviously are laparoscopy, hysteroscopy, fertility enhancing surgeries, ultrasound, color Doppler, 3D, 4D ultrasound, IVF, ICSI. She is working on exclusive
Dr.
single
Asha, thank
embryo
you so
transfer.
much.
Welcome, ma'am.
Yeah, thank you so much, Dr. Asha, for those very, very kind words. And my heartiest congratulations to you and the whole team, for this wonderful Searchlight program. I think it's a great knowledge sharing series, and you've done a great work. Dr. Asha has always been doing a good work, and she's been into my committee, and we've got a lot of associations, and so much of hard in work efforts have always been there through Dr. Asha. So, Dr. Asha, wishing you all the best. And I think our committee will keep flying when you are there with us. And my regards to our chief guest, Dr. Nandita Madam, most respected and admired Nandita Palshetkar Madam. And we have our guest of honors, Dr. Anuradha Khanna Madam, Revati Madam. I think we had long association with Revati Madam and Anuradha Madam. Both of them have been our mentors. They are so near and dear to us, and they're always there for us whenever we meet them. So it's so happy to have them here as the guest of honor. And our aptly chosen speakers, Dr. Ramani Madam and Dr. Geeta, I think they are masters in their field. And we've got so many societies and representatives, Dr. Amita Sharma and Seema from Jalandhar. Monica, hi. Monica is there from, Bhopal as the vice president. And Monica, all the best wishes to you also. And Dr. Pratibha is there from Kadirganj. Dr. Sonia is from Sirsa, and Shashibala is from Vijayanagar. So happy to see you. I think we've been in touch in many of the webinars and all, and maybe into physical meetings also. And this panel, Dr. Asha, you've done the best thing you've done. You keep the young, brilliant panelists, and I think they're going to give you the best. They're just the fresh ones. And this panel, I think, is really going to rock. So all the best wishes for the webinar. And that also focused on LSCS. And to all the aspirants, Asha, Monica, all the best for your future endeavors. So thank you so much for having me here. Nandita, madam, good evening.
Hi, good
Thank you
evening.
so much. Welcome, Dr. Nandita. Thank you for joining. And
Hi, Nandita.
Hi.
Good
Sorry,
evening.
I was in a seminar, so I had to,
Yes.
sorry, I got delayed a little bit.
I
Ah.
thought as much.
Good evening, Nandita ma'am.
Good evening, good
Okay,
evening.
ma'am, what's the problem?
What happened? Hello?
Ma'am, I think
Namaskar, ma'am. Namaskar, Dr. Nandita. Actually, Ramani ma'am was having a problem, so she called me up.
Oh, okay.
So, so welcome. We all know Dr. Nandita Palshetkar, ma'am, a very happy, ever smiling, ever helpful person. Thank you, ma'am, for joining us today. She was the president of AMOGS, past president of Mumbai, past president of Foxy. She is also the FIGO representative, president of Indian Society of Gynec Endoscopy, VP Federation of
Asha, it's
Obstetric.
okay.
Yes,
Everybody
ma'am.
knows. Thank you
Welcome, ma'am.
so
Welcome so much.
Thank you so much. First of all, Dr. Revati Janki Raman, Dr. Anuradha Khanna, Dr. Ritu Khanna. And of course, I'm on the mobile, so I can just see a few faces. Asha, I think first of all, I must congratulate you that, your passion, your focus, and your dedication that you want to, do work in women's health. I think it's amazing. I applaud you for that, and I wish you all the best in your election. And of course, I can see Dr. Shashikala, Dr. Pratibha. Hello, Dr. Anuradha.
Hi.
Dr.
Nice
Revati is
to
your
see you.
Monica. All the best for you.
thank you,
Uh,
ma'am.
yeah, so I just want to say that you've taken a very fabulous topic today, LSCS. I think it's very, very important because it's one of the commonest surgeries performed in OBGY today. And a fabulous speaker like Ramni and others who are going to talk about it, I think it'll really, all the difficulties, all the problems will be discussed. And I think most importantly, the indications. It is very, very important to discuss that. And I'm so happy that you've taken this very, very important topic. So, all the best and do well. Thank you. Thank you so much. Sorry, I'm in the middle of a
Thank you so
seminar on
much.
obesity.
That's all right, ma'am. That's all right.
Okay.
Thank you so much for joining in. Thank you so much.
Thank you.
Thank you, Nandita ma'am.
Thank you.
Good evening, Nandita ma'am.
Good evening. Good evening.
Thank you, my respected dear guests, for joining this program. So, thank you, Nandita ma'am. Thank you, Revati ma'am. Thank you, Anuradha ma'am. And thank you, Dr. Ritu. All of you, thank you so much for being here and gracing our program. And if you can stay around, we would be really grateful. But if you cannot, that's fine because you have other commitments as well. So now we would be starting the scientific session. I would request Sujayshri to please introduce our chairpersons. Sujaya?
Yeah, ma'am, I'm here. So, moving on to the first session, which is ideal LSCS, we have, the first session, which is ideal LSCS, we have Chairperson Dr. Amita Sharma, who is the President of Jalandhar OB-GYN Society. Welcome, ma'am, to today's session. We have Professor Monica Singh, ma'am, who's known to all of us. Madam is currently the founder president of ISOPA Bhopal. She is also she's been the vice president of Bhopal OB-GYN Society, and she is also the vice president of Bhopal Menopause Society. Managing committee member Isar. So, ma'am, it's an honor to have you with us here
Thank you
today.
so much. Thank you.
And ma'am, the next slide, yeah. We have Dr. Pratibha Yashwant Chavan, ma'am, with us. She is from the Sant Gajanan Maharaj Rural Hospital.
From Gadingla's Gynae Society.
Yeah, so it's an honor to have you with us here today, ma'am. I request one of you to please introduce the speaker, Dr. Ramani, ma'am, today. She will be talking on ideal LSCS.
So, can I introduce?
Yeah, please, ma'am, do the honors.
I at the outset, I would like to thank Dr. Asha Jain and Ritika ma'am, Food, Drugs and Medical Surgical Equipment Committee Chair, to have me here in this program. This is my first visit to Searchlight, and I'm thoroughly impressed by the whole show. Congratulations, Dr. Asha. We know she's a perfectionist, and now I have a speaker who is par excellence, Dr. T. Ramni Devi ma'am. I have had the honor of introducing her before, and I take pleasure in saying that Madam is a mentor for many, Managing Director of Ramakrishna Medical Center, LLP, and Janani Fertility Center, a gold medalist during UGPG, who has had IVF training abroad as well as in India, winner of Professor C.S. Dawn Prize and Indumati Zaveri Prize, C.S. Dawn Prize again, 2016. She has chaired the Endometriosis Committee of Foxy with aplomb and won 5 trophies as the VP of Trichy Obs and Gynae Society. The recipient of Women of the Year Award, Women Achiever Award, member of Consensus Group for Endometriosis Asia Pacific, and recipient of Dr. APJ Abdul Kalam Award. Madam, we are so honored to have you. Your list is exhaustive, but I think I've spoken the best awards, and the award list is so impressive. She has been the National Vice President of Foxy 2020, and she is on the International Advisory Board as a member of Fertility Society of Bangladesh. We are honored to have you as a speaker, ma'am, and ma'am would be deliberating on LSCS now. Is Madam able to display her slides?
Dr. Ramni ma'am?
Ramni ma'am is there? I think Madam has not joined.
Yeah, ma'am's not logged in yet. She was here a short while.
Madam's computer is hanging.
Oh.
Ma'am,
We don't have Dr. Geeta ma'am also, otherwise we could have started the next talk, ma'am.
hello. Requesting my chairpersons to discuss LSCS amongst themselves while the speaker, goes on. Shashikala ma'am, Dr. Monica, Dr. Pratibha, if you can just, because cesarean is an everyday thing, while ma'am joins, if you could discuss certain points, that would be great.
Okay, it is very, very useful topic in our day-to-day practice. First, we will face difficulties in baby deliveries. One is in floating head, deeply engaged head, and abnormal position and presentation, transverse lie and breach, multiple pregnancy and conjoined twins. Second is in difficulty, we will face sometimes so many difficulties in taking incision. Previous LSCS, dense adhesions between uterus and abdomen, excision of the scar, opening. Sometimes we will face very difficulty in opening the abdomen, and sometimes dissecting the bladder peritoneum. So difficulty in placental delivery. So difficulties in abdominal closure, difficulty in controlling the hemorrhage. So there are so many aspects to discuss here, and it is very, very, very useful topic in day-to-day practice.
Madam, what is your opinion about delayed cord clamping? Should it, because now it has become the norm, Shashikala ma'am,
Yeah.
it should be followed in all the. Okay, ma'am. So any particular case where we will avoid delayed cord clamping?
RH negative mother,
RH
as well
negative.
as in the preterm babies also.
Preterm babies, RH negative mother, ABO incompatibility.
What about, ma'am, multiple gestation twins? Twins, 35-weeker twins or 36-weeker twins, would you still delay the cord clamping or would you proceed?
I don't have many experience in this.
Yeah. Because sometimes twins, especially in our ART practice, sometimes they do not reach a gestational age of 37 weeks.
You have to delay, I think.
Sometimes we have to deliver by 35, 36 weeks. That is why I asked this question.
Thank you.
But again, it depends upon the twin to twin transfusion syndrome, and such type babies are there. Then there is a difference in both twins, no weight. And that time for one baby there may be delay, and for another upon the weight of the baby. Means, are you thinking like that?
Asha?
Yes, ma'am. Especially
I have joined. Okay, sorry. Yeah. There is some.
Welcome, Ramni Devi, ma'am.
Yeah, thank you.
We have introduced you, Ramni ma'am. We have read your CV, very nice CV and all the awards, and we are blessed and honored to have you amongst us to speak about ideal LSCS.
Thank you.
Ramni ma'am, I just got to know that Geeta ma'am's son has fallen sick, so she would not be able to join.
Okay.
So if you want to take your time and describe a few difficulties also, that is fine.
Okay, we'll see.
Yes,
so I bring you greetings from Rock City, that is Trichy, and you can see the beautiful river Kaveri, which is full of water now, and Lord Vigneshwara Rock Fort. And this is the UNESCO accredited center at Srirangam Temple. Okay, so according to the legend Julius Caesar, he was supposed to be born by operation, and hence the origin of the term cesarean. Most important modification was the lower segment transverse incision that was made by Herer, and then it was popularized by Mandroker. We all know about Mandroker-Muller's technique. So the study of incidence, trends, and determinants of cesarean section in tertiary care hospital of Rajasthan. This is an Indian data where the most common surgery performed worldwide is cesarean section. And the ideal rate according to WHO is 10 to 15 minutes. But increased incidence in the worldwide during last 28 years. In India, the incidence is about 31% and 91% were between 20 to 29 years of age, and emergency LSCS happens in 72% of the cases and primary LSCS in 66.5%. So cesareans, according to the director of WHO, that is Ian Ashko, cesarean sections are absolutely critical to save the lives in situation where vaginal deliveries would pose risk. So all healthcare system must ensure timely access to all women when needed. But not all cesarean sections are carried out at the moment are needed for the medical reason. Unnecessary surgical procedures can also be harmful both for the mother and her baby. This is according to the director of WHO. Now, what do you mean by cesarean section? Cesarean section is a C-section, is a delivery of the fetus through the incision in the anterior abdominal, that is laparotomy, and the uterine wall, that is a hysterotomy. The common indications for cesarean section are maternal indicators, fetal indicators, feto-maternal indicators. And then now coming to the maternal indicators, it is mainly due to dystocia, that is the cephalopelvic disproportion, tumors complicating pregnancy, especially in the lower uterine segment, obstructing the outlet, and non-progressive labor, threatened rupture and obstructed labor, failed forceps and vacuum, and deep transverse error. And antepartum hemorrhage like placenta previa, abruptio placenta, vasoprevia, carcinoma cervix, and medical disorders. These are the commonest indications nowadays. Preeclampsia and eclampsia are hypertensive disorders, and HIPs are the common medical disorders which are the reason for a cesarean section. And of course, coarctation of aorta and certain cardiac conditions, they warrant cesarean section. The maternal obstetric problem can happen in elderly nullipara when there is a prolonged period of infertility and pregnancy following IVF, I would say rather it is only a, like when you're going to do it for a male infertility, then only the risk is IVF, but not the maternal age or so. We can definitely allow IVF patients with a vertex presentation and an average, maybe we can allow even for a normal delivery. Bad obstetric history, previous repair of nulliparous prolapse, stress incontinence or fistula, or failed induction. So the fetal indications are mainly fetal distress, congenital malformation. I think we should take away this because most of the congenital malformations are now identified in the first early trimester before 20 weeks, and they can be the women can undergo MTP. And of course, small presentations and breech is one of the most important cause fetal indicator. The contraindications to cesarean section is there is no contraindication to cesarean section if the fetus is live. But some of the absolute indications are severe degree of contracted pelvis, placenta previa, presence of abdominal encerclage, soft tissue obstruction, previous 2 or more seizure, and previous repair of vesicovaginal fistula. Then, when you take the timing of the operation, cesarean section may be one elective or it may be for an obstetric emergency. If you are going to do it for an obstetric emergency, then the time limit should be only maximum of 30 minutes from the decision that you are going to do a Caesar to the start of the procedure. So the common types are mostly we go in for a lower segment cesarean section. Of course, lower segment vertical incision can be done in patients with a premature preterm delivery, and classical cesarean section very rarely done unless when the lower segment you cannot reach it, or in cases of placenta previa where we are planning for a cesarean hysterectomy. And of course, extraperitoneal cesarean section that comes on its own default, we get into the extraperitoneal plane. See, I find off late this extraperitoneal cesarean sections are becoming more commoner in my practice because most of the previous sections when we deliver, they are all adherent anteriorly. So we don't have any other way other than to go in for an extraperitoneal C-section. So the extraction of the baby is done through an incision made in the lower segment through transperitoneal reed. It is commonly used method practice in day-to-day practice. Is it possible always? LSCS approach is difficult when you have dense adhesions in the previous abdominal operation or severe CPD with a pendulous abdomen, or in very obese also we find it very difficult. And again, LSCS approach is risky in a big fibroid in a lower uterine segment, CA cervix, repair of high vulvovaginal fistula, complete anterior placenta previa. So the classical cesarean section, everybody we are aware, the incision is made in the upper uterine segment where you have to suture it properly. So perimortem C-section, just for a completion check, if the patient is in a grave danger, probably if you are able to do a quick cesarean section within 5 minutes, then at least we can save the baby. Now, after deciding what are the indication, then deciding for C-section, first thing we have to see is to get a proper consent for cesarean section. We have to explain the procedure, indication should be correct. We have to discuss the risk versus benefits and alternatives to C-sections. Also, we have to discuss post-operative expectations of the patient and the patient's question regarding how early, how long it will take for the surgery and what is the type of anesthesia, what are the complications, early and late complications, how well she can return. All those things we have to answer the patient. Then documentation in the regional language is very important, and consent during emergency situation. See, even though it may be an emergency situation, as far as the patient is concerned, it is always a must to get a consent from the husband or in the very close relatives. So that too, I think if the patient is able to give a proper consent, it will be better. So then the preoperative preparation is, first is informed consent. Then timing of elective surgery is preferably in the morning. Never do the surgery in the midnight. And then the abdomen should be scrubbed, and then with an iodine solution, hair may be clipped. We don't now go in for a shaving. Pre-med should be given. Then pre-medicative sedation must no need to give sedation in the as a pre-medication, and non-particulate antacids can be given orally before transferring the patient to the theater, because in order to avoid the aspiration syndrome. Metoclopramide and ranitidine may be given before the anesthesia. Then bladder should be emptied. FH should be checked. Presence of neonatologist should be there. Cross-matching of the blood. If suppose the patient has got a negative group of blood or patient is basically anemic. Then the preferable anesthesia is spinal or epidural anesthesia, or very rarely we go in for a general anesthesia when the spinal is not possible, or for example, in a kyphoscoliosis where we are not able to reach it. And then the position is dorsal position, antiseptic painting and draping should be done. And types we have already discussed. It could be either a lower transverse or upper segment in certain selected cases. And in patients where you are not able to extend the transverse incision, maybe instead of going for a T-shaped incision, we can go for a J-shaped incision, because T-shaped incisions are always likely to give way in the next pregnancy. And always, if you do a T-shaped incision in difficult situation, make a big note of it and you tell the patient, so that in the subsequent pregnancy, she may not be allowed for a VBAC. Then steps of the cesarean section is: first open the abdomen transversely, the Doyen's retractor is introduced, loose peritoneum of the lower segment is cut transversely, a short incision is made in the midline down to the membrane, and incision of the lower segment is being enlarged using index finger. So sometimes we can use the scissors to open up clearly. So then the membranes are ruptured if it is present intact, and blood mixed with the amniotic fluid may be sucked out, and then the Doyen's retractor is removed. You can put the head can be delivered by hooking the bed with the fingers, which are carefully introduced between the lower uterine flap, and the head in the palm is placed below the head. But sometimes when it is a floating head, when it is a deflex, maybe we can use a forceps delivery or a vacuum to deliver the fetal head during cesarean section. The head is drawn to the incision line, and the assistant can apply the pressure, and the head can be delivered using either Wrigley's forceps or Barron's forceps or vacuum. Now, after that, after the head is delivered, or the mouth is being sucked, and the pharynx, nostrils, everything is cleared, and then you can put the baby over the mother's abdomen, and then cord can be cut and clamped. And after the delivery of the shoulders, you can give IV oxytocin 20 units, or carbitocin can also be given based upon the patient. Some people are using regularly tranexamic acid to prevent reduce the postpartum hemorrhage. But when we are using tranexamic acid, we have to be very careful, because sometimes the drugs, today also there was a talk by one professor from UK where he said accidentally this instead of carbitocin, they have there can be change of the drugs, like when they have given the spinal analgesia, instead of anavin, tranexamic acid was given. So we have to carefully see what is the drug, then only we can give. And before giving carbitocin immediately after the delivery, we have to find out whether there is any contraindication. We have to assess that earlier, and then you choose oxytocin or carbitocin. Then comes the removal of the placenta and the membrane. By controlled contraction, the placenta is expelled. Unless if the placenta is not separated spontaneously, you can use manual removal, can also be done. But routine manual removal is not preferable. All membranes should be carefully removed, and if there is a succincturate lobe, you have to clearly assess that and see to that your uterine cavity is closed, uterine cavity is empty. Then coming to the suturing of the uterine bone, always it is better to hold the angles with the angle of all both the sides. It can be caught with the green armitage, and if there is any bleeding, if any tear of this uterine artery, it should be clamped separately and it should be tied separately. And then the closure of the uterine incision is preferably by 1/0 vicryl, and it should be done in proper layers. The basic teaching for surgical closure is close as you open. So you can approximate the uterine incision by 2 layers. And the RCOG guidelines also says either you can use 2 layers or you can use single layer. So whatever it is, the preferable mode of closure is always preferable to do a 2-layer closure, and it should not be it should not be this one locking suture, preferable to use a continuous suture. So we should take the deeper muscles, and previously we thought that we should leave the decidia, but that concept is gone now, and it should not be too tight also because it is going to cause necrosis. And the most important thing is when you put the incision in the lower uterine segment in a patient who has already got into labor, it is always preferable you put the incision slightly at a higher level, because otherwise it is likely to cause niche in subsequently. So then continuous suture is placed, and then again the superficial layers are closed, and then the closure of the peritoneum, visceral peritoneum, it depends. Many people, they do not close the visceral peritoneum, but it's always preferable to take 1 or 2 sutures. Then close the peritoneum, then you separate. The muscle should be approximated gently, and then rectus sheath should be closed. So then once when you do the uterine closure is done, put the uterus, when you are going to do the uterine closure, preferably the uterus can be exteriorized so that the angles are made out clearly. Once everything is done properly, you can put the uterus back to the peritoneal cavity, give a peritoneal toileting, and then peritoneum can be sutured, and abdomen should be closed in proper layers, and vaginal cleansing for bleeding, blood clots, and sterile vulval pads should be applied. So the first 24 hours after the post-operative care is very, very important, because the patient has to be kept in the post-operative ward for a period of 6 to 8 hours, and she has to be monitored for the pulse rate, BP, amount of vaginal bleeding, and behavior of the uterus. Preferably in the post-operative ward, the staff nurses who's looking after the patient can put a mark at the upper limit of the fundus of the uterus, so that she can pick up whether there is any intrauterine collection. Then the fluids, the IV fluids have to be managed properly around 100 to 125 ml per hour, or you observe the urine output and then calculate accordingly. And blood transfusion is helpful only in anemic mothers for a speedy post-operative recovery, and you have to follow the ERAS protocol so that the patient can become all right as rapidly as possible. Then prophylactic antibiotic, preferably cephalosporins, can be given, and that should be given just soon after the baby is delivered. And then you can continue cephalosporin, either a single dose or a dual dose can be given after 12 hours apart. And for then it can be followed up with the analgesic drugs, and proper analgesia should be maintained during the post-operative period. That is, you can give rectal suppositories can also be given. And then if the patient is on a epidural analgesia, then continuous epidural analgesia can be provided. Then you can make the patient ambulant, and within 6 to 8 hours after the delivery. And then she is encouraged to move her legs and ankles, to breathe deeply, minimize the DVT and pulmonary embolism. And then heparinization is given in needed cases. And breastfeeding should be initiated as soon as the patient is shifted to post-operative ward, and semi-solid should be started on day 1, and the patient can very well be discharged on within 3 to 4 days. Now, indication for classical cesarean section, we have already discussed. That is when lower uterine segment, when you are not able to reach it, central placenta previa, dense additions in perimartum C-sections, where you want the baby to be delivered very rapidly, and when the baby is in the transverse slide also, but I don't think this is only a relative indication. And when you want to do a hysterectomy following cesarean section for central placenta previa, you can go ahead with classical cesarean. What are the merits and demerits of LSCS? All of us know that LSCS is always a better one, because it has got a better healing as it is in the lower uterine segment, and future rupture is very rare. And we can go in for VBAC is also possible when the patient has got a lower uterine segment. And then this is transverse incision is always has cosmetic appeal. Post-operative pain is low, wound dehiscence is low, there is a lower incidence of incisional hernia, and but you need slightly a more technical skill, and the time taken for a lower segment uterine transverse incision may be slightly higher, and but only thing is you cannot access the upper abdomen. It's not possible with the transverse. So all those things are, opposite to that, you can have it for a vertical incision. Now, coming to what are all the complications of the cesarean section, intraoperative complication is primary hemorrhage, injury to the internal organs, and difficulty in delivery of the head, anesthetic complications to the mother, shocks related to blood loss, iatrogenic prematurity, respiratory distress syndrome to the baby, injury to the baby due to surgical knife, and birth asphyxia of the baby due to anesthesia. So the primary hemorrhage on table can be very easily managed by good judicious use of oxytocin or carbitocin, or if it is not responding, maybe then we can go in for an immediate venous suture or a stepwise devascularization. And injury to the internal organs like the bowel and the bladder occasionally can happen when you are doing it for a repeat cesarean section. And sometimes there may be difficulty in delivery of the head when it is totally a floating head or when it is in a deeply engaged head. When it is a totally a floating head, probably forceps application might help. But if it is deeply engaged, then probably you need to go for a Patwatan or reverse Patwatan technique, or sometimes, most commonly we do the push from below and then deliver it. So the anesthesia complications can be spinal shock can happen. And then if you are going to go for an elective section, iatrogenic prematurity has to be ruled out. And probably now we are giving a shot of corticosteroids, even though the patient has received it at 28 weeks. We are giving a shot of corticosteroids just before the delivery. That is to prevent the respiratory distress. And injury to the baby, we have to be very careful. And sometimes, very rarely, you can have, as you are delivering the breech baby, you can have some fractures for the baby. So post-operative complications are the common post-operative immediate complications can be PPH, you have to have a watch, then paralytic ileus, respiratory complications, infections, peritonitis, pelvic abscess, pelvic thrombophlebitis, DVT, and pulmonary embolism and wound dehiscence. So all these things are all quite preventable, and we have to anticipate infection when it is a case that has been handled outside, or when you are given a prolonged time for trial of trial. So, but that all those things we have to carefully monitor, and accordingly we can increase the, you can top up the antibiotic dose or combine with the antibiotics to cover the polymicrobial infection. The delayed complication, I would say, is it's an incisional hernia can happen. That is most likely to occur in our vertical RPM incision or a vertical incision. And very rarely it is seen in the transverse incision. But even in the transverse incision, you can see the hernia occurring at the lateral border of the incision. Between the rectus sheath and the peritoneum, you can have the hernia can happen. And then chronic pelvic pain following cesarean section is also known to occur because of adhesion. And currently, many of the secondary infertility patients, they have a higher incidence of secondary infertility when they have previous LSCS. This is because of the when they don't close properly the layer of peritoneum, what happens is the uterus can get adherent to the posterior abdominal wall, and it gets pulled up, and automatically the cervix is also goes behind the pubic symphysis. And in the previous cesarean scar, you can get the niche formation that is also likely to happen, and the collection of blood in the niche area will prevent the implantation, and then secondary infertility can happen. Again, very rarely uterocutaneous fistula can happen, and recently I had a case of uterocutaneous fistula following a C-section that was done outside for a previous LSCS, where the doctor has clearly mentioned that it was a very badly adherent and she has to go through a transverse, that is an inverted T-shaped incision. Probably on the 3rd month after the cesarean section was done, she developed a uterocutaneous fistula, which was repaired properly. So the main reason for this, I would say, is we have to prevent adhesion formation, maintain hemostasis, and do a proper layer closure. So this can prevent adhesions, and then subsequently it may not cause any problem. So this is a case, you see the uterocutaneous fistula, and then when I inserted the cannula, you can see the dye is coming through the suprapubic transverse scar. And this was the bad, the entire anterior abdominal wall was having a track with the uterocutaneous region, and that we had nicely dissected it out and sutured, and this was the posterior surface, which was very clean. And the patient subsequently returned back after 3 months with a regular menstrual cycle without any bleeding through the womb. Then cesarean hysterectomy, it refers to an operation where C-section is followed by removal of the uterus. This happens in morbidly adherent placenta, atonic uterus, uncontrolled PPH, big fibroids, grossly infected uterus, and ruptured uterus. So extraperitoneal cesarean section, I have already mentioned, it is a very, very rare condition. Very rarely we come across this, and it was practiced in the past in cases where severe infection is there and when they didn't want to enter the peritoneal cavity. Lower segment is usually approached extraperitoneally by dissecting the space of LSCS. So, where the sterilization during cesarean section, it is an extended process where you can have a portion of the fallopian tube being cut, excised, and then sutured. And it is usually preferably done along with the second cesarean section or thereafter. So the LSCS at maternal request is coming up in a big way. And here we must analyze why women seek elective LSCS. That is probably because of the fear of labor pain, previous traumatic birth, control over the delivery timing, and it is not uncommon for people come and requesting that this is a auspicious time and we want to have the surgery between that time. So that can also, that is also a reason why women seek LSCS, or rather the family seeks, and concerns about the pelvic floor injury. Risk and considerations are, if there is we have to tell them that there is increased recovery time, surgical risk, anesthesia risk are there when the LSCS is done at maternal distress, and impact on the future pregnancies and respiratory distress for the baby. But ACOG recommends that C-section should be performed on basis of medical necessity rather than that of the maternal request. Now, there is a definite place for physiotherapy. In the postnatal period, the patient has to go for a deep breathing exercise, early ambulation, arm exercise, postural correction, pelvic floor exercise, abdominal strengthening exercise. All those physiotherapy is needed. And what are the post-operative goals? We have to prevent the infection, promote circulation, prevent post-operative complication, and then decrease the incisional pain associated with coughing, movement, or breastfeeding, and improve healing of incision and can prevent adhesion formation, prevent pelvic floor dysfunction, improve lactation, and prevent sagging of the breast, and correct posture should be advised. So what the RCOG guideline says is we have to go in for C-section depending upon the maternal and fetal indication, counseling and concern, patient's autonomy has to be respected, timing of elective LSCS preferably at 39 weeks or at least beyond 38 weeks, and less than around 37 weeks when the patient has got a hypertensive disorder or hyperglycemia which is uncontrolled. Then surgical technique should be planned one, and the intraoperative and postoperative care should be good. And TOLAC, we can allow the patient for TOLAC. That all depends upon only if the previous surgery is done in a proper ideal way. Then we can, emergency LSCS is still, it has to be managed, and the delivery of the fetus should be within 30 minutes, and proper post-operative follow-up and counseling for contraception and VBAC should be done in the earlier first pregnancy itself according to RCOG, and audit and quality improvement and individualized care. These are all the guidelines that is given by the Royal College. So the take-home message is C-section should be performed under optimum conditions, ensuring best outcomes for both the mother and the baby, and it should be done for valid reasons. It should be done at the right time, neither too early or too late, maximizing the safety and minimizing the complication. There should be minimal trauma, reduced recovery time, and low risk of infection and other complications. Safe environment and team with the appropriate anesthesia, good post-operative care, pain management, and wound care and monitoring the complication. Obese patients, they need a very special care. So finally, I thank the opportunity, and I know I am contesting for the post of ICOG Vice Chair elect. Please do support me. Thank you for listening to my presentation. Thank you.
Thank you
Over
for an
to you,
excellent
all
deliberation, Ramni
chairpersons.
ma'am.
Thank you.
That was so comprehensive, lucid, and crystal clear. And the volume of your experience speaks through your words. And we are
Thank-
blessed to listen to you, ma'am. Thank you, Asha ma'am, for this wonderful opportunity.
Thank you.
Thank you,
Asha
Dr.
madam.
Monica, for being here. Yes,
Yeah.
please.
Asha madam, I have a TNFOG EC meeting. I have to leave. Sorry. Otherwise, I will stay back and discuss with all the complications and rare conditions where we are facing problems in LSCS. Anyway, thank you for the opportunity.
Thank you so much, Ramani ma'am, for being here with us. You know, in spite of all the odds, you managed it. And you really covered a lot of things. And I have excellent chairpersons who are going to take me across in the other part. So thank you
Okay.
so much, ma'am.
Thank you. Thank you.
And all the best.
Thank you. Thank you, Asha. All the best for you also.
Best wishes, Ramni ma'am. Best wishes
Thank
from
you.
us.
Thank you. Thank you. I'm leaving.
Okay,
Sure.
ma'am.
Thank you, ma'am.
Yeah.
Now, I would like, Purvi, would you introduce our second session chairpersons? I would, if
Yes,
they agree, I would have them as experts in my panel because we are going to cover everything anyways.
Yes, ma'am. So I would like to take this opportunity to introduce Dr. Seema ma'am. Dr. Seema Pasricha ma'am. Ma'am is MBBS Gold Medalist, MD Obs Gynae. She is Director at Pasricha Hospital and Maternity Home, Consultant in Jalandhar. She is practicing in the field of gynec, obstetrics and infertility over 25 years now. She is a visiting fellow at Royal Free Hospital, London, UK. President Jalandhar Menopausal Society. Next, I would like to introduce Dr. Sonia Garg ma'am. Ma'am is working as a senior gynecologist at DCH Sirsa, chairperson of DAC, in charge PMSMY, in charge menopausal clinic. I would like to introduce Dr. Shashikala Gugri ma'am, consultant obstetrician and gynecologist in Hosapet since 1991, founder CEO of Gugri Hospital, Hosapet Field of Interest Infertility Charter member and president of Vijayanagar Obstetrics and Gynecologic Society, District Vijayanagar. Ma'am, you're muted.
Thank you. Now I request the chairpersons who are present here, if they can spare the time to please join the panel as experts. I have included Dr. Pratibha Chavan ma'am, President of Girl Hinglaj Society, as our expert. She is a consultant obstetrician and gynecologist from Gajanan Maharaj Rural Multi-Speciality Hospital, Mahagaon. And it is a tertiary care unit including a cath lab, radiation unit, blood bank at Gad Hinglaj. She is also the president of Gad Hinglaj Society. Welcome, Pratibha ma'am.
Thank you, ma'am.
Now we have 5 dynamic young gynecologists who are going to be with us. Dr. Shreya Panda is SR at AIMS Raipur. Dr. Kirti Sinha is SR. She was SR at MG, MMC and MTH Hospital, Indore. Has publications and, Kirti, if you would please introduce yourself, where you're working right now. Unmute yourself, please.
Am I audible?
Yes, yes.
Good evening, everyone. I'm Dr. Kirti Sinha. I'm currently working as an SR, fellow in PDCC high risk pregnancy at AIMS Raipur.
Dr. Priyanka, would you introduce yourself? Priyanka?
Yes, ma'am.
Please introduce yourself.
Hello. Am I audible?
Yes, we can hear you. Yeah, we can hear you.
Good evening, everyone. I'm Dr. Priyanka Mandal. I have just passed out MS OBGY from AIMS Raipur last month only. And I have my 1 month tenure left here. So I'm doing my 3rd year residency.
Okay. Dr. Pallavi Golhani.
Good evening, everyone. I'm Pallavi Golhani. I've recently completed my 2.5 years RSHIP 1 year from NSCB Jabalpur and 1 year from AIMS Raipur, and have recently joined as an assistant professor in RIMS Raipur.
Dr. Samita? Dr. Samita?
Good evening, ma'am. Am I audible?
Yes, you're audible.
Yes, ma'am. I'm Dr. Samita. I have just passed out MS OBGY from AIMS Raipur, and I'm currently doing my 1 month tenure left here.
Okay, if you would please have your videos on, I would be really grateful, because it's easy then to ask the questions. And we have our senior chairpersons who are going to be there for us and be the experts. So let's pray to the divine and start. So this is a picture that Ramani madam has already shown, which is the cesarean section being performed. Can anyone tell me what are the Robson's criteria? Means this chart is there, but can someone explain it, or 2 or 3, one by one you can explain it, and then the seniors will tell you what it actually means.
So basically, Robson devised an elaborate criteria system for classifying the indication for which a cesarean section is being taken. According to it, all the indications have been divided into 10 groups, such as number 1 is for nulliparous singleton cephalic woman who is into spontaneous labor. Number 2 is nulliparous singleton cephalic with an induced or a cesarean section before onset of labor. Criteria number 3 is for 3 and 4 are for multiparous.
Kirti, please wait.
Just it depends upon the parity, like that previous car, like that you explain.
No, see, this is nulliparous, and then it is saying cesarean section. So what does it actually mean? Because this is nulliparous, singleton, cephalic, more than 37 weeks, induced labor or cesarean section before labor. So it is this pregnancy, or is it a past pregnancy?
It is this pregnancy where cesarean section is taken before the onset of labor.
Induced labor or cesarean section before labor?
Okay. I'm deliberately confusing you so that everything gets cleared. So now we go to the third point.
So Robson number 1 and 2 are basically for nulliparous women. 3 and 4 are for multiparous women. Again, multiparous without previous cesarean section, a singleton cephalic presentation more than 37 weeks in spontaneous labor. Number 4 is for a multiparous woman without previous cesarean section, singleton cephalic more than 37 weeks, induced labor or cesarean section before the onset of labor. So these are all basically primary cesarean section. They could be in a nulligravid patient or a multiparous patient. Now, number 5 are multiparous with prior cesarean section. These are cases of repeat cesarean section. Number 6 covers all nulliparous with breech presentation. 7 is with all multiparous with breech presentation. 8 is for multiple pregnancy, including previous cesarean section. Number 9 is for all pregnancies with transverse or oblique line. And number 10 is for all preterm cesarean sections.
Okay, but this is less than 37 weeks. Number 10 is less than 37 weeks. And all others are above 37 weeks.
37.
Okay. Now, where would a woman who has had an IVF pregnancy and she's having twins now, and she's less than 30, she's 35 weeks, where would she fit in here?
Number 10. Number 8. Number 8 are all multiple pregnancies. Number 8, ma'am.
8. Number 8.
Number 8. So the thing is, now government wants us to classify all our cesarean sections retrospectively as per this. So we actually need to understand it properly. What is Robson's criteria? I have a very senior gynecologist with me here. Anuradha ma'am, are you still there? I don't know if she can hear me. I come back to Shashikala ma'am, who's the senior most right now. Shashikala ma'am, do you think this Robson criteria will help us to reduce cesarean rates?
Hello? Definitely.
Hello. Monica, just wait.
Anuradha ma'am.
Actually, I'm on a call, Dr. Asha. I will.
Okay. Later, ma'am. That's all right.
Monica? Yes, Asha, I can answer you. I will ask. Okay. Okay. Yes, Asha, please tell.
Ma'am, I was asking that do you think implementing Robson criteria will decrease cesarean rates?
No. I think.
Why not? Why not?
Yes, I'm telling you my reason. That obstetrician has to understand the baby and the mother. If you go for a lot of criteria, whether this or that, you can put it on your mind. That is more important, that you understand the body, understand the fetus. If you just think of criteria, this is my feeling. I'm not against of any criteria, but I just understand that thing, this is a baby, these are the things, why it is not going well, why should I go for cesarean? The question I raised to myself, why should I go for cesarean? What is the indication? Is this baby is not going to come out? If I will be diverted towards so many criteria, am I justified to go with the patient and the baby? This is my question to me. That's why I'm not very much in favor of so many criteria which are coming and going. This is my feeling, Asha. Because since I have joined as an MBBS student and now I have been retired also. So why you need any criteria? I don't understand. Because we know ourselves, we know our baby, and there are so many equipments have come to understand what is the well-being of the mother and the well-being of the baby. So this is my reason.
Okay. Shashikala ma'am, and then Dr. Pratibha, I will come back to you. Shashikala ma'am, do you think applying these criteria will reduce the rates of cesarean section?
Even I'm not favoring for this, madam.
Okay. Dr. Pratibha?
I in favor. Criteria should be applied while teaching. During teaching institute only, they should teach their PG student for the clear-cut indication and for the trial of labor. They should promote the trial of labor, and there is so that unnecessary cesarean section might be reduced. I feel
that I agree, but I agree with Shashikala ma'am and Anuradha ma'am that applying this criteria will not reduce cesarean rates. What does it have with reduction? It cannot reduce. But it will help us to classify and talk to us about why we are doing the cesareans. What are the patients that are undergoing cesareans? Dr. Jaideep keeps on saying that we should not talk about reducing. We should talk about optimizing cesarean section rates. That means the patient who needs it gets it. The patient who doesn't need it doesn't get it. That is optimization. And that rate doesn't have to be 10, 15 or any such percentage. On Foxy website, there's a big discussion. There's a big paper on this, the Foxy's point of view on optimizing cesarean section. I think everybody should go and read that paper. Do that. But because the government now wants us to retrospectively classify all our cesareans as per Robson's criteria, we need to actually know the criteria. So thank you, Kirti, for explaining it. Now we come to the questions proper. That how do these criteria aid in understanding the causes and contributing factors to the rising cesarean section rates globally? Shreya? Please put on your
Ma'am, this.
videos.
Hello, ma'am.
Requesting all my people to please put on your videos. Very difficult to talk otherwise. Yes. Tell me.
Ma'am, this Robson criteria puts a light to know in which criteria we are underdoing the more cesarean section. It's like an audit. It will tell us that according to WHO they say that there should be only 15% cesarean rate. But if we see it in our institute or any other institute, the rate of cesarean are equaling to the rate of normal deliveries. So Robson criteria tell us in which group we are taking the patient more towards cesarean section. For us, in our institute category, the Robson 2 and Robson 4 rate of cesarean sections are very high, even the Robson 3, ma'am. So, yes, ma'am.
So, how do maternal indications for cesarean section, such as PIH and placenta previa, impact decision making? Whenever there is severe PIH or placenta previa, do you even think of normal delivery, or you just want to go ahead and do a cesarean?
Ma'am, it's always the mother which first comes to a obstetrician's mind when it is weighing between a mother and a baby. So during that time, no criteria, nothing. It's straight away, we need the mother, so we take her for cesarean section and expanded the
No,
delivery.
but in PIH, deliveries are sometimes very easily done. Even eclampsia patients have delivered very nicely vaginally. So once you've given them a lot of Maxilf, they usually deliver. So do you ever try pre-eclampsia, severe PIH to go for delivery, or you would take only for cesarean? I want everyone to answer this. Each one.
We can go for trial of labor. But if,
no, I'm not talking about can go. Do you actually give a trial of labor? Do you do it in your practice? That is the question.
Yes, ma'am, we give. We usually induce the patient and prime the cervix. If it is favorable, we can wait for normal delivery. If it is not, the bishop is not improving and the patient's BP is on higher side, and we are suspecting that there may be an impending eclampsia, then we usually take her for LSCS.
Even so many times patient came with labor pains, and that time also it is easy to deliver by controlling, stabilizing her vitals.
Yeah. We have to use a short trial of labor, madam. After stabilizing the patient, we can give, after giving Maxilf, patients will will have normal delivery.
Yeah. So giving Maxilf, so basically the cesarean has to be for obstetric indications.
Yeah.
Not because the mother has PIH. Placenta previa is a obstetric indication. If the placenta is less than 2 centimeters from the os, you have to do a cesarean section. So what is your take on, the patient comes in labor, do you do an ultrasound or don't you do an ultrasound?
Yes.
Not every patient, even now in our country, will have an ultrasound before she comes for delivery. So do you do an ultrasound when she comes, or you don't?
Ma'am, if she had a already ultrasound report, then we rely on it and go forward. But if she doesn't, we do get ultrasound done for her before progressing.
Do you have an ultrasound in your labor room?
Yes, ma'am, we do have.
Do you do it or you send her?
No, ma'am, we do it.
We do it.
You're doing it?
Yes, ma'am.
Okay, good. So, anybody wants to say anything on this point?
Even if previous report is there, but in labor sometime while per vaginal examination, we feel some different part, or we feel there is no proper engagement of the head or any presenting part. That time also we can immediately do the ultrasound in labor room.
Yeah. So now, fetal distress and malpresentation. How frequent is that in your practice now? Fetal distress, cesarean because of fetal distress or due to malpresentation? Means
Ma'am,
supposing
now
there are 100 cesareans, so how many would be because of fetal distress or, malpresentation? Presentation is different from malrotation, right? So
Ma'am,
here breach, transverse.
ma'am, in our practice, usually cesarean sections due to fetal distress are in a increasing trend. I can say that is mostly because of gradually the rate of induction due to many indications are increasing, and if we can uh, and we are giving trial of flavor uh, even in cases of uh, in cases priming with some with borderline pelvis, then but we need to identify that uh, at proper time so that we can intervene properly. And regarding malpresentation, I would rather say malpresentation better to be ruled out before induction and
No, no.
before
What
patient
is
goes.
the percentage of malpresentation? Supposing there are 100 cesareans, how many would be malpresentation? You are all in a big institute. So how much malpresentation do you see? Breach or transverse? What is
Around
the percentage?
10%, 10 to 15% malpresentation.
Okay.
And because of continuous CTG monitoring, there is easy pickup of the fetal distress is very common. Even our staff is telling middle of the night there is fetal distress and there are deceleration because of NST monitoring. And it is easily available now with each gynecologist, and that's why fetal distress is picked up very nicely.
Well,
And that's why
WHO
cesarean
has
section
a
is
paper.
increased.
WHO says that you don't even have to do a continuous monitoring because continuous monitoring is causing more of cesarean sections.
Yes.
So you
That is
should do
true.
a every 15-minute monitoring by a Doppler. So how do you agree to this? Do you agree to this?
Yes, yes. I am agree.
Yeah.
yes, ma'am.
Means, see, if you have a CTG that is showing deceleration, there has been one single deceleration. Will you take the patient for cesarean?
No.
No,
ma'am.
So what is the criteria? How much of deceleration would you see before you take the patient for cesarean? Because we have to remember wherever we are, shifting the patient to OT, getting the anesthetist, getting the instruments together is also going to take some time. So how much are you going to wait before you proceed and do that cesarean section?
Ma'am, for the CTG, if it is a category 3 CTG, if there is a late deceleration which is prolonged, we take her for cesarean section, we don't wait.
Give me, I don't want theory, I'm asking you. Means how many seconds of deceleration during which period? 10 minutes, 20 minutes, 40 minutes? What are you looking for? A single deceleration? Or you're waiting for more than one deceleration?
Ma'am, in a 10-minute strip, if I found a deceleration, I will make it, I will wait for 20 minutes more. If there is further 1 or 2 deceleration, I will wait for 40 minutes more. For that time, I will resuscitate the mother with IV fluid left lateral position and give her oxygen 5 to 6 liter by face mask. Then if it has disappeared, then I will wait. If it is recurring, then I have to take the decision. I will inform the consultant in charge and then plan accordingly.
So my question to you now is, what could be the cause of this deceleration? You have assessed the pelvis is good, the woman has gone into labor. So what could be the cause? Why this deceleration is occurring now?
Ma'am, I have to first categorize the deceleration, whether it is early, late, or a variable deceleration.
You have the deceleration, you have the late deceleration, it is prolonged, it is persistent. Okay, now I'm asking you.
The deceleration due to the drugs.
Yes, ma'am, it can.
Yes, it can be due to the drugs that we have to remember. So
yes,
what are the drugs? Because see, what is happening these days, patients will go to court. They gave injections so that the baby suffered and then they did a cesarean section. People are talking like that. So what are the drugs that actually cause deceleration?
Oxytocin induction
Even major for
And
Prostaglandins induction.
they would cause acceleration. They would not cause deceleration.
Even sometime in the late phase, there may be post-contraction drops. Patient may be almost dilated, and that time there are, for few seconds or few minutes, there may be deceleration. And that time immediately we can cut down the second stage of the labor and we can deliver the baby.
Yeah, so it is because of the head compression. The normal thing that during the process of labor, the head is compressed, and because of that head compression, immediately the deceleration will occur. But after the contraction, it should go away.
Yes.
There is another thing, a silent thing that we previously used to mention: right and left cord round neck. What is the contribution of that cord round neck in this?
Ma'am, cord around neck, the condition in itself is.
Yes. Yes, Dr. Pratibha, please go ahead.
If there is, even if the cord around the neck, we have to give the trial of labor, but during the trial of labor, we have to look after the NST frequently, because there may be chances of pulling of the cord or tightening of the cord during the labor contraction. That's why we have to monitor that case, and then we have to deliver. So many times we are delivering the baby and we are removing the cord and then we are cutting it. And that is very common. That's why that is not the indication for the cesarean section. But sometime on ultrasound, there may be 2 or 3 cord loop around the neck may be seen. And that time there may be difficulty for engaging the head also. And in that situation, sometimes
so if there is no engagement, you have to take for cesarean. Fine.
Yeah.
Now, does age play a role in cesarean section?
Yes, ma'am. Age plays a role. Because now age of pregnancy is also getting delayed more than 30 years. So patients are less tolerant to the normal deliveries.
So what age do you
along with the age, also there is association with the PIH as well as GDM. These factors are associated many times because of the age. And in infertility conception, again, that is a precious conception. And so that chances of increases in.
And what about parity? We are getting more primiparous cesareans or multiparous cesareans?
We are getting
definitely primiparous.
Primiparous.
And previous one cesarean section, again indication for cesarean section. That's why increasing rate.
Okay.
Because even with the previous one cesarean section scar, this TOLAC or VBAC, that we are trying, but sometimes patient may not be ready. Pain tolerance, lifestyle changes, sedentary lifestyle, so many factors which are affecting while private practice. Means we are facing those problems.
So if I have done a cesarean section, and now that patient in her second delivery is coming to you, okay, and she says that I've had one cesarean and now I want to have a trial of normal labor, would you do it?
Yeah, I will assess her pelvis. I will look for her weight of the baby, her BMI, her Bishop score, and according to that I will try. And what if there is a recurrent indication, and whether there is a recurrent indication for the cesarean section. If that is for indication for the CPD, I will not give a trial of labor. If there is previous cesarean for placenta previa, but now there is no placenta previa, I can give. If the adequate pelvis for adequate baby weight is adequate, then I can give a trial of labor. And Bishop score is also important.
Shreya?
And duration before, how much duration before that cesarean was done?
Okay.
Inter-delivery period.
Okay, Pallavi, what do you say?
Yes, ma'am. It will depend, like at what facility I am working. If it is fully equipped for giving TOLAC, and then like ma'am said, we'll see cervix condition and whether patient is already in spontaneous labor, and if it is a non-recurrent condition, then we can give her a trial.
My question was very specific. What my question was, somebody else has done a cesarean section. You have operative notes of cesarean section done, baby delivered, cried after birth. you don't have any notes, right? This is what you get these days. Would you give that patient a trial?
Ma'am, I will ask some certain questions to the patient, like at which facility she was delivered, whether there is an elective cesarean or emergency cesarean, then how long the case took, whether there is any use of intraoperative or postoperative blood transfusion, postoperative wound gaping. If these histories are there, I will not give her a trial. I will take up her for elective cesarean section only, because these indicate poor wound. So she may rupture during the TOLAC.
Okay, one thing I want to ask all of you. Have you thought of looking at the scar by ultrasound?
Yes.
Scar integrity. Yes, ma'am.
We are looking for the
There are
scar.
two things. You would actually touch that scar and see if there is scar tenderness. You would also try to look at it by ultrasound. Yes or no?
Yeah. Scar thickness we are taking.
Where do you take that scar thickness?
And we have to take it throughout the scar, like previous scar, not
at previous
one particular.
cesarean section scar, approximately in that area, with good full bladder, we can able to visualize properly in front of the head.
Because see, when you are doing a gynec ultrasound, you're seeing that isthmocele. So means it has been there, right? So it would be present in a lot of patients of previous scar as well. So when you are measuring the thickness of that scar, what do you measure? Do you measure the uterine wall? Do you measure along with the peritoneum? Do you measure it along with the bladder? What are you measuring it with?
Whole
If you're
uterine
measuring, you
That's
actually
why I told you.
want to measure it, the myometrium of the previous scar with the serosa. Okay. And when there is no pain, then you can measure the wall of the bladder as well, but that doesn't work so well for you. We actually need the myometrial thickness. Now, what is the myometrial thickness where you not allow her to go for delivery?
3 mm ideally. Less than 3 mm. It should be more than 3 mm.
Pallavi, you want to add something?
Less
Yes,
than
ma'am.
or equal to 2.5 mm.
2.5 mm is the critical figure where you don't want to go ahead. Shashi ma'am, would you like to add something here?
It should be less than 3 mm.
Okay. So now everybody said that when you induce labor, there are more chances of
rupture.
No, this is a nulliparous patient, primary, of the baby going into fetal distress, landing in cesarean section after induction of labor. Can somebody tell me why?
Sometime meconium may be passed during labor.
No, ma'am, agreed, but why? If there is induction of labor, this is more than 37 weeks, but it is not yet 40 weeks. And why do these patients end up in cesarean section? Why do the babies have distress? When you open up, what do you find?
Lower segment may not be formed properly.
But then why should the baby have distress? A 28-year-old first-time mother,
Maybe lung maturity may not be proper. Sometimes there may be mistaken dates also. Some 1 week gap difference may be there. So that proper assessment of the maturity is also very important for 37 weeks.
So what are the specific
So that induction of the labor is always...
What are the specific risks in a primary? It is an untried horse. You actually, the best pelvimeter is the fetal head. You cannot know that it is absolutely adequate till it has passed through. She is 28, she is not 30 years old. Okay. So what is the evidence that says that you should induce labor at 39? Why, whenever a patient needs induction, why do you want that induction at 39 weeks?
I think there is no need to induce at 39 weeks. If everything is normal, Liker is normal, Doppler is normal, we can wait till 40 weeks or 41 weeks also. And we have to wait for the she should go in spontaneous labor because there are much more chances of section after induction. If we
Shashi
want,
ma'am, would you like to add something here?
No, we have to wait patiently, madam. We should not induce. If everything is okay, we have to wait. What I feel for the normal onset of labor.
There is one trial, ARRIVE trial. After that, AICOG has recommended induction after 39 week if no any harm to
But
mother
why?
and baby.
Why? You read that trial. There is
Because
one
ma'am,
data there that supports 39 weeks. What is it? The stillbirth rate and the maternal mortality rate is minimum at 39 weeks. After that, it steadily rises. So, if everything is favorable, you need to do it. If not, if there is an obstetric indication, you need to do it. If there is a maternal indication, you need to do it. But you don't have to do it for everyone.
Yes.
You don't have to do it for everyone. That is the crux of that study. That if there is any kind of complication, then 39 weeks is fine. But otherwise, wait. So I will go with what Dr. Pratibha and Dr. Shashikala ma'am said, that you wait. Wait till the patient goes into labor and monitor the fetus. So if you have given oxytocin, you've given prostaglandins, how do they affect the likelihood of cesarean delivery? What is the difference between the contractions caused by oxytocin and prostaglandins and natural contractions?
Contraction by oxytocin, after oxytocin induction, if there are hypertonic contraction, immediately after stoppage of the drip, the contraction stops. But in case of prostaglandin, this will not happen.
Another thing is
Ma'am, the strength of contraction in normal labor, in the normal delivery, it's a rhythmic contraction. There is contraction, relaxation. During the relaxation time, the baby gets the blood. But when we are inducing it, oxytocin also does the similar kind of thing in a controlled way. We can control it by the drip rate controlation. But if we give prostaglandin, it's beyond our control. It will cause the uterus to contract and can cause more distress to the baby, leading to more rise in the cesarean section rate.
Sometimes there could be abrupt placenta.
One more thing is that when you are, yes, ma'am?
Oxytocin, what in my practice, I'm very happy with the oxytocin induction.
Okay.
But again, that depends upon the Bishop score. Means a different indication for oxytocin and for prostaglandins also.
Oh.
See, one thing is what everybody has a CTG now. So
Yes.
when you apply the probes on the maternal abdomen, in a natural contraction, you will have a single peak. But with any induced contraction, you have a peak, it goes down, goes up again, and then comes down. So it is a twin peak, one peak bigger than the other. So this is the difference in the type of contraction which interferes with the fetal blood supply. Okay, so now what are the points where you decide that this induction has failed? What are your points to decide a failed induction?
Partogram should be
joined. Otherwise, we can say also failed induction when after if we are using prostaglandin gel like cerviprine gel for cervical happening and induction of labor, then we can say after 24 hours.
Okay, 24 hours.
Irrespective Yes, we can. You tell ki even after induction, 24 hours later, if patient doesn't enter into active labor, then we can say this is failed induction.
Okay.
With maximum,
Okay.
Kirti,
would you like to add something here?
Yes, ma'am. Basically, there could be maternal indicator and fetal indicator for failure of induction. Maternal indications, as highlighted by Dr. Samhita, that 24 hours after our last trial of labor, if there is no active progression of labor, then it could be termed as a failure of induction. Or if the fetus ends up showing signs of fetal distress in terms of CTG findings or with our intermittent auscultation, then also it is a failure of induction.
Okay. So I have, who else is here? Pallavi, would you like to add something there?
Ma'am, we have also read that a laboring woman should not see a sunrise or sunset twice once she has been induced. So, if even after 24 hours, as Samita said, if it is not progressing,
you have induced the lady. Okay. This 24-hour cutoff starts from where? It starts from active labor. It does not start from induction. You have to understand that. And that needs to be very clear. You have put in Serviprim gel. The patient, the cervix has not responded. The baby is fine, mother is fine. Will you go ahead and do a cesarean?
No.
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 No. So what are the pointers for a failure of induction?
Partangram should be maintained during labor.
Yeah. So what are the action points, Dr. Pratibha? What are the action points where you say, this is where I'm going to take her for a cesarean?
That again, according to dilatation of the cervix is not progressing. Action line is there on the...
Ma'am, but the action line starts at 4 centimeters.
Yeah,
it starts at 4. It doesn't start before 4. So you have seen the Bishop score. You are sort of dicey and you have put her on prostaglandins. 12 hours later, you have started her on an oxytocin drip and nothing happens. Nothing has happened. It remains 2 centimeters. Will you call that failed induction?
Yeah.
These are practical things, that we have very senior people here whom I want to clarify these doubts, because when you're dealing, right now you're in an institute, but when you are dealing with your own patients, these questions will come to you. What now? What now? So Shashikala ma'am, what would you like to say here?
You have to go for section.
Yeah, you have to go for section, agreed. But here the most important thing is, why did you induce in the first place? If there is a maternal indication, if there is a fetal indication, then you need to progress and do a cesarean section. If there is no change in the cervical and fetal parameters after the duration of effect has occurred. So Serviprim will be at least 6 hours. Yeah. When you're giving oxytocin, you have to wait for at least 4 hours. You will see twice. And when there is no progress only, then you will decide that now you need to go for a cesarean section. You cannot apply a drip for 2 hours and say, no, ab kuch nahi ho raha hai, now we take for cesarean. Right? How do you decide the endpoints? Either the baby has a problem or the mother has a problem, then you immediately take. But if both of them don't have a problem, then how will you take a decision? That is my question.
We have to wait, madam.
Yes. When there is no problem, you have to wait. You have to wait. Serviprim can be inserted twice. Oxytocin can be started again the next day. You can withdraw it and then restart again. So these are practical things that we need to do. So now here, what is the role of patient counseling? And what role does the patient have to play in this? What does she think? Induce kiya hai? Whatever her expectations are, do you think that has an effect on the outcome?
Yes, ma'am, that
Yes.
definitely has an effect on the outcome because we have to keep the patient in loop for whatever we are doing. We have to explain to her what can she expect out of anything that we are doing to her. For example, labor is a natural process largely controlled by maternal hormones and biochemical reactions going on. Anxiety has a very big part playing in how the labor is progressing. So we must do steps to correct the anxiety level of the patient, and that could only be achieved by proper counseling. What we call is verbal counseling. So in that way, we have to explain why we are inducing the patient, first of all. Second, the method of induction should also be discussed with the patient. For example, if we are putting in a gel, or if we are giving misoprostol, or if we are starting with oxytocin, then we have to tell the patient that, okay, I'm doing this. My period of wait is expected to be around 6 hours. After 6 hours, if I'm putting a gel, after 6 hours, I will be reassessing you for the progress of labor. I will be continuously monitoring you and your baby for the well-being. If everything goes fine, after reassessment, we can plan for either a repeat induction, or if you enter the labor, then we will let it go smoothly as required. So patient counseling is the first, foremost, and very important thing to do whenever we are doing with an induction of labor. It always should go ahead with a written valid consent.
Yeah, consent is necessary, as well as I feel counseling should be started from the 9th month only during our OPD. That will be helpful.
Agree. Now we come to the consent part. When are you going to take the consent? If a woman has come to you, when are you going to take consent for delivery, for instrumental delivery, for induction, for cesarean? When are you going to take this consent?
When she goes in labor, when she come with
Once we
labor
have
pains.
decided, once we have decided our plan of management, ma'am, if we plan that the patient is to be induced, we take a prior consent and then proceed for induction.
1 minute, please,
In
ma'am.
that,
One emergency has come. Shall I go?
Yes, ma'am. Thank you, ma'am. Thank you so much.
I'm very, very thankful to you for giving me an opportunity. I'm very happy.
No, ma'am. Thank you so
All the
much.
best.
Thank you for being
Thank
here.
you, Vandana.
Thank you, ma'am. So, Shreya, what were you saying?
I was saying once the patient comes to us and I plan where I want to go for, if there is a maternal or a fetal indication, I want to go for an upfront cesarean section. Before proceeding for that, I'll take a consent if the patient is willing or not. So it depends on what I plan to do for the patient.
And what
And then I
justice
will write out the
to
prescription.
you, I will tell you what is medico-legally correct. If a woman has come to you in labor, consent is not valid. It is not valid for anything. Because as per the rules by the court, anything taken during pain is invalid. So when you have decided what is going to happen to her, or even if you don't know, there are 4 options. You need to explain all 4 options and take her consent before she goes in labor. You have to take 1 witness from her side, 1 witness from your side, or better 2 from her side and 2 from your side, and have the consent ready. Foxy website has those consents and it's written over there that which date the consent was taken. Now, if she has come to you with pains and then you take the consent, that whole paper is crap. It will not stand in a court of law, provided the woman has any kind of complication. So please remember, when your woman is coming in the 3rd trimester, put that paper in there, explain everything, and get her to sign it long before she goes into labor. You can put all the options. You know that these are the things that can happen. But all consent has to be pre-labor. It cannot be during labor. Is that clear?
Yes.
And what if patient is not booked? She is not a booked case.
For unregistered case, what to do?
Unregistered case, ma'am, then.
See, you will take her consent, but you have to understand that it doesn't stand. If she is in pain, no consent taken during pain is there. Then you would have to
relatives
explain.
are there.
Ma'am, legally, relatives are just witnesses. They cannot What happens to my body is not decided by my relative. It is decided by me. It is suggested by the doctor. So in that case, it has to be clearly written that she has come for the first time during this, and we have explained, and her guardians, legal guardians, legal relatives have consented to this along with her. She always remains primary, but here you will also take consent of her relatives. Okay? But remember
Yes, ma'am.
this, that try to, any booked patient, put that consent form right there starting 28 weeks. Okay? Now this is the second case, which a multiparous lady, she has a previous cesarean section. She is more than 37 weeks. She is in labor at 38 weeks. How will you decide whether you want to give her trial of labor? What are the criteria to decide TOLAC?
Again, Bishop score is important, as well as her BMI is important, as well as birth weight of baby weight is also important. That is estimated by clinical examination as well as by ultrasonography. And what was the previous indication for the cesarean, whether it is a recurrent indication?
Okay. So what are the recurrent indications? Pallavi? Dr. Pallavi?
Yes, ma'am.
What are the recurrent indications?
Ma'am, like in a CPD, cephalopelvic disproportion.
Is CPD a recurrent indication?
No, it is a non. Ma'am,
Ma'am, it's contracted pelvis.
Contracted pelvis.
Contracted pelvis. Contracted pelvis.
Yes. And
then, ma'am, uterine anomalies. If patient, then in that situation also, will not give. And
A tumor occupying the lower
upper
thigh.
segment incision, T-shaped incision, previous placenta previa, anterior placenta, likely to have adhesions, likely to be abnormal. So these are recurrent indications, and you will also see, and if it's a transverse lie which has been in labor for some time and then cesarean was done, then also that part of the uterus becomes weak, and you do not wait for that. Now, if the patient has had a cesarean 1.5 years back, and there is another patient who had a cesarean 3 years back, and there is another patient who had a cesarean 7 years back, which one would you try for TOLAC? There is no recurrent indication. Then which one would you try for TOLAC?
Middle one, 7 years.
3 years.
7 years or 3 years?
3 years.
3 years.
Middle one.
3 years. Because 7 years she would be elderly and we would have to evaluate her all over again for obstetric and gynec conditions, medical conditions, and decide. But 3 years is the one whom you can give a safe trial at that time. So how would you monitor her? What are the monitoring protocols?
We have to look for maternal pulse, fetal heart rate,
scar tenderness.
Scar tenderness. Then fetal monitoring with.
Yes, Shreya?
Ma'am, with all the preparedness for emergency cesarean section, we will be monitoring the pulse rate in the per-abdominal examination for the scar tenderness. During the per-vaginal examination, we will be watching for the fetal station, the fetal heart rate to be monitored by the by the CTG monitoring every 4 hourly, and then we will tell the patient if you feel that suddenly the pain has gone, if you suddenly feel there is a gush of bleeding, or you feel dizzy, if you feel like passing
that
the urine,
is already too late, my dear. That is already too late. She has ruptured.
We will be more vigilant.
You don't want her to rupture in front of you. So will you be looking at her temperature and blood pressure?
Yes, ma'am.
Yes.
When you
Vital
are
charting
already
would be
doing a
increased.
CTG, will you be seeing the wave pattern of the uterus or
Yes,
not?
ma'am.
Yes, ma'am.
Yes.
Okay, so you have kept her on continuous CTG. If there is impending rupture, what is the wave pattern?
There will be fetal decelerations and loss of beat to beat variability.
No, I'm not asking on the fetal part. I'm asking on the uterine part. In your CTG, you have a cardiotocograph, right? The toco is the uterus. So you are seeing the uterine waves. What will they be?
They will be
Double
lost,
tweaking
ma'am.
may be there. Double
What
twitching
did
may
you?
be there because of contraction.
Double tweak are there. It does not come back to the baseline. It doesn't come back to the baseline. The height is higher, which you don't want. How much height do you want for a woman to deliver? What is the CTG tracing where you think it's an adequate contraction? We all keep looking at the baby. We don't look at the mother, and that is where things go wrong. The topography part, what are the waves that you see in a successful TOLAC? They would not rise beyond 90. Okay. Ab dekhoge to dekh ke batana next. Okay. So what are the advantages of a successful vaginal birth compared to cesarean section? I'll ask both things. What are the benefits and what are the non-benefits?
Surgical
side
complications are avoided.
Yes.
In subsequent delivery, PAS will be more in a repeat cesarean section compared to vaginal delivery.
Blood loss is less.
Yeah.
Less risk of
It may be
postoperative
more, ma'am. You
complications.
don't know.
Yeah.
Your placenta may get stuck. The baby has come out. The placenta is not
That again
coming out. You
depends
don't
upon
know.
the
Yeah.
hospital
But you
stay
have an
will be
abdominal
reduced.
scar and you also have a perineal scar now. That is there. Right? So the advantage is that cesarean section has a slightly higher morbidity and mortality that is reduced. Now, when the woman has come to you, does her choice decide how you're going to go for it, or you decide on your own?
Her choice is also.
Her choice decides, but we need to counsel her regarding the expected outcome of both the things. Informed choice determines the next that we are going to do.
That is absolutely correct. So it has to be a shared decision.
Yes.
It has to be a shared decision, whether you take it or the patient takes it. And it has to all be documented. Has to be all documented. Okay? So now we'll go really fast. This is a case where an emergency cesarean was done due to fetal distress. She's 40 weeks. What would you find on a CTG that indicates fetal distress? And what would you find clinically that indicates fetal distress?
Deceleration on the CTG and meconium clinically may be there. Most common.
Okay.
At 40 weeks.
So you would see meconium. Supposing it's very thin meconium and the heart is normal.
Patient is
Would you
about to
consider
dilate.
that? Would you consider that as
indication? No.
No. Thin
It will
meconium.
depend on cervical
It
status.
depends upon the how much is the dilatation.
So if it is like 3 centimeters and there is meconium, then?
Ma'am, if cervix is favorable, like if we can give a trial, and if NST is also reactive.
See, there is meconium now. She's only 3 centimeters. So technically, she's not in active labor. Would you want to give her oxytocin at this stage when meconium is already present?
No.
No, ma'am.
No.
No, ma'am.
Grade 1 meconium, we can give oxytocin because it is not a marker of an acute change. It reflects
But we have
any
to
time in
explain the
during the
relatives and patient.
period. If there is any chance of fetal distress, there might be thin meconium or grade 1 meconium could be there. So these patients with adequate monitoring can be given a trial of labor. However, if it is a thick meconium which plaques, then the baby is at a risk of aspiration. So here we are not going to give any kind of augmentation. We will be assessing the current status of vaginal
So
delivery.
you
If it is
will
favorable for-
watch her without augmentation. That is what you
Yes,
mean to
ma'am.
say. Okay. So now you think that there is some mild distress. So what is intrauterine resuscitation?
Intrauterine
Left lateral
resuscitation,
push.
basically when the baby is in situ, we apply corrective measures to improve
Like?
oxygenation by placenta. For example, left lateral position could be given, hydration of the patient could be improved with ringalactate solution, and oxygen at the maximum rate which can be provided. So these are the three basic mechanisms. Previously, intraamniotic infusion of crystalline solution was also done, but now it is not recommended. So these three are our intrauterine resuscitative measures.
Okay. Okay. So this baby, a baby that is born by cesarean and the baby that is born by vaginal delivery. What are the long-term and short-term consequences in these babies?
Baby of fetal distress.
Yes.
A baby of
a
fetal distress
vaginal
which has
delivery is going on and the baby delivers. That is one thing. The baby the baby goes into distress and a cesarean is done. So what is the long-term and short-term consequences of this? Being born in fetal distress.
basically the short-term most important thing is the transient tachypnea of newborn, which is encountered more frequently in babies delivered in emergency situation. Now, this transient tachypnea of newborn, if it progresses into hypoxic injury, that depends how long that baby has been in distress. It can progress to HIE also, depending on how long the baby has been hypoxic. So, if a baby is born by vaginal delivery, it is seen that it has a better outcome provided the delivery time is shorter. In babies delivered by cesarean section, if it is taken in a timely manner, then that baby is going to survive more as compared to a vaginal delivery that has taken a longer duration. So everything depends on what was the duration of distress that the fetus was subjected to.
So question. What is the duration of distress that you can allow the baby to have? Because now we know that we now have done early IUGR, we've done late IUGR. So there is a baby who is full term, maybe 3.2 kg, will tolerate deficient oxygen for a shorter time, right? Compared to a preterm baby who will tolerate it for a longer time, right? So now your 40-week baby, how long will it stand oxygen deprivation? What is the duration? Five minutes and it's dead. So when you are doing your CTG, you need to see that it's coming back to baseline. If there is shouldering seen, then you're not waiting at all. So you need to take the patient for cesarean as soon as you see shouldering. Okay? You know what shouldering is, right? In a CTG, when that deceleration has occurred and then it's a level and then it goes up. That's the shouldering. So supposing a cesarean is done in the day compared to one that is done maybe 3 o'clock at night, is there a difference in outcome?
Ma'am, the neonatologist and the expert obstetricians are usually available during the daytime. So if there is a fetal distress baby during the night time, it might not get a expert hands to be handled. So there
Whole
is a
team may
slight
not be
difference in the
available.
outcome.
Team is not available.
There is less manpower during the night time.
So no induction in the night. Induction has to be early in the morning so that you can handle all emergencies in the day. Obviously, nighttime emergencies are not so good. Now, this patient has been on trial of labor. She's been eating and drinking and enjoying herself. And she suddenly has to be taken for cesarean section. So what is the anesthetist worried about here? And what steps are taken?
Aspiration.
How is it? How can it be mitigated? How can it be mitigated?
Patient can be put on liquid diet during the active phase of labor.
That is one. And the other?
Acids and
before
antacid.
taking for OT, antacid and perinom we can get.
Metoclopramide.
And
Trials tube for preventing aspiration could be given.
You need to put in a Riles tube and clean out the tummy because aspiration is very common in these women. So now we come to the next question. Now this is a breech. She is at 38 weeks. She has been scheduled for a planned cesarean section. So what are the guidelines? What do guidelines say? Should every primee with breech, does she require a cesarean section?
Ma'am, the trend is like right now we recommend primary breech as an absolute indication for cesarean section. However, again, we need to discuss the options with the female. At centers where external cephalic version is done, it could be offered at term to a patient where it is usually practiced. Otherwise, vaginal breech delivery and elective cesarean section both need to be discussed well with the patient. For example, if she chooses
Means
to
what is the absolute cutoff where you will not allow that lady to even think about vaginal delivery? When will you say that, nay, you have to go for cesarean? What is that cutoff?
When the baby, when it is a large for gestation or a heavy weighted baby, for example, 3.8 kg, it is an hyperextended head or the pelvis is not adequate.
See, in our conditions, what is the weight of the baby? In our conditions, our women, what is the weight we are discussing?
3.5.
It's 3 kg.
Again, depends upon every female is different. Her stature is different. Her pelvis is
But
different.
for an average Indian woman, the weight of more than 3 kg is not considered safe for a vaginal breech delivery. Okay, that is one thing. And plus whatever you have said. So if you want to do an external cephalic version, have you ever done it?
No.
Have you seen it?
No.
No.
Okay. So theoretically, what is a major risk of this version?
Landing into labor, abruption,
Rupture of membrane, abruption, cord prolapse.
Cord pulling.
fetal distress.
Okay, because you actually, if it's an anterior placenta, you're not going to be able to do it anyways. You will only be able to do it if it's a posterior placenta. And then there is cord entanglement. You don't know how much liquor there is, whether it's even going to move or not. And even if you have been able to make it vertex, you don't know whether it will turn out posterior position. So, is there anything special when you are doing a breech cesarean section? If it is a footling, what will you do? If it is an extended breech, what will you do? You must have done cesarean for breech, right?
You have to hold the baby's limb and then pull slowly and make the back anterior. Back should be anterior before hooking the shoulders.
So would you take out both limbs or you would just take out one and try to take out the baby?
Both limbs, if possible.
Okay. And if it is an extended breech, what would you do?
Directly we can deliver by pulling breech.
How would the head be delivered? Head in a breech, it's an after-coming head. Whether you do a vaginal delivery, whether you do a cesarean, that space is just 10 centimeters, right?
Routinely, we are putting index finger in the baby's mouth and we are flexing the chin towards the chest. and then we are delivering it.
And with the other hand, you're supporting the neck of the baby?
Yeah.
So one you're putting inside, one you're putting on the back, and then you're taking it
Lifting
out.
up and then down. And telling assistant to pull the incision to hold back.
Okay. Now, supposing that lady is very, very like 110 kg. Then is there anything special that you want to do?
Forceps we can apply.
Vacuum.
You would just need more assistance. The surgical
Yeah.
procedure remains the
Surgical,
same because you need to hold the abdomen separately, right?
This is breech.
And if there is a uterine anomaly, you have to take care of what? Supposing it's a unicornuate uterus.
We have to take care that our incision do not extend laterally.
Yes.
Or backwards.
On the side of the uterine vessels. Okay, that you have to take care that it should not, because the space is half, and so that problem is there. In breech, is the post-op care different or is it the same? Cesarean section you've done for a vertex or you've done for a breech. So is the post-op consideration different or is it the same?
It's the same.
It's the same. Yes. So now there is a twin pregnancy, DCDA twins, 37 weeks and planned for elective cesarean. Why was she planned for cesarean? What are the indications in a DCDA twin? She's 30 years old and she has DCDA twins.
Maybe malpresentation.
The presenting twin position. Yes. The presenting twin is non-cephalic. And if they are both cephalic, when would you still want to do a cesarean section?
If other indications, associated indications are there, like...
No, here let us just talk about the babies.
Not
so
even
in
one
these
head
babies...
is engaged.
Okay, not even one head is engaged, the other is?
If there is
Both
conjoint
heads
or both
No,
the
it's
heads
not
are presenting
conjoined.
at
See, you have DCDA. You have DCDA. Dichorionic, diamniotic twins. So what is special about this? Why?
If the both the head are presenting at the pelvic inlet, the collision of the head can occur.
What can occur?
Collision
See,
of the head.
One head has gone down, the other is now acting like a valve and stuck to its neck. Won't allow any progression. That can also be there. Okay. And if there is the presenting one as breech, you can think, what is special when you're doing a cesarean section for a breech? Not breech, for a twin pregnancy. You've taken that patient for a cesarean section. You have incised the uterus. Now what? You have a cephalic presentation. You've delivered that baby. Now what?
We have to assess the second baby's presentation. Sometimes it may be changed during labor also, during section also. And we have to see.
And we will rupture the membrane for the second baby. And then we will try to deliver the second baby. If the first baby is fine and does not need early cord clamping, so we will deliver the second baby and then we will clamp both the babies and hand over to the pediatrician.
Okay.
If it is,
will you immediately rupture the second sac or you will wait?
No, ma'am, we will wait for it to come down. Otherwise, it would be a high floating
assess
head
the
to deliver
presentation of second baby.
Yes, because you have to wait for a couple of minutes so that the uterus can contract a bit. Otherwise, if it doesn't do that, then later chances of PPH, malpresentation, and difficulty in fetal extraction are also there. Okay, so is the anesthesia different for twins?
No, ma'am.
No. So now we come to the last case.
After delivery of the first baby.
Exactly. They should give whatever they have to give after the second baby is born, not after the first is born. So that is very critical. So this is 39 weeks transverse lie, planned cesarean section. Okay. So you have confirmed that it's there. How are you going to take out that baby? What is going to be your incision and how are you going to take out that baby?
Routinely, we are doing by financial incision. Nowadays, we are not taking midline vertical scar. And after taking incision on the uterus, we try to usually we try to find out the baby's foot or any accessible part. If it is
See,
very near,
the thing is, it's a transverse line. Now this hand is like this, right? It has come out. You gave that incision and that hand came out. What will you do now?
We are pushing hand inside again, and then we are searching towards the limbs. Means foot usually.
So you are trying to convert that into a breech and deliver it.
Yeah.
Yes, ma'am.
Yes, ma'am.
Like a footling breech.
Yeah. Anybody wants to differ?
Ma'am, it is a dorso-posterior breech. Dorso-posteriorly, if the transverse lies, this foot are samne, so we can take it out easily. But if it is a dorso-anterior, we take it out as a footling breech. Either of the condition, we take it as a breech, but it is more difficult in dorso.
Again, decided that immediately on that within seconds on the table.
Okay, so basically, if that hand comes out, you are going to push it back. If a bit of cord comes out along with it, what will you do? Will you push that back, or you are more
pushing it? We are pushing.
Push it back.
Push it back and then take out as a breech, right?
Yes,
So now we come to the take-home messages. Please ask your friends, whoever are president and secretary of any society, to vote for me. Please, thank you so much. And we will now just have a take-home message discussion before we end the session. Okay? Who is this Raj? Pratibha ma'am, I'll take you last before I take the children, okay?
Yes.
Pallavi?
Yes, ma'am.
First take-home message to you from you for the entire cesarean section session.
Ma'am, about the informed consent, like as you said, we should take it prior patient goes in labor. So
Priyanka, please put on your video. I want to take a photo of all us panelists. Yes. Who is Raj, by the way? There. I have the picture now. Ma'am, I'll share in the group right now. Pratibha ma'am, I'll just share.
Yeah.
So, who is Raj? Please put on your video. And Pallavi, we start from you. Start with the informed consent.
Yes, ma'am. Likewise, you said it should be taken before patient goes into the labor, so that it is medico-legally also it is correct. So nowadays it is essential for us to be medico-legally safe. So we should put in a habit to take consent prior, and should also counsel and explain patient before everything during antenatal period before she lands up in labor.
Okay. Samita? You're muted. You're muted. Everybody unmute yourself.
Ma'am, this is a planned delivery, whether it is a cesarean section or induction of labor, we should plan it properly, and it should be shared decision by the doctor and the patient party, and so that we can be aware of, we can intervene properly, and
Dr. Priyanka, you're
Ma'am,
next.
yes, ma'am. Ma'am, unindicated cesarean section we should not do. We should avoid indicated cesarean section. We should give trial in primary breech patient, in multi-breech patient. We should do more VBAC after shared decision making and proper counseling of the patient with proper arrangement in a tertiary setup. And we should counsel the patient from the first trimester only regarding the successful vaginal outcome and to decrease their anxiety of undergoing vaginal delivery. That's all. Thank you.
Okay. Shreya, you're muted. You're muted.
Ma'am, as everybody said that the consent is the foremost important part. Apart from that, I will try to be more vigilant when I am giving a VBAC. I will definitely remember to look at the Toco probe and that tonic peak after the 90. I will look into it, ma'am, and surely let you know.
Thank you.
Thank you.
Thank you. Kirti?
Ma'am, first of all, thank you so much for this very engaging session. We learned a lot of things that were previously presumed by us as misconception. So I would like to basically highlight three things. First of all, classification of all the indications into Robson's criteria is not going to help us in the short term, but all going to help us in the long run for proper auditing and proper revision of our indications. So classification of all indications into Robson's is very must. Second, training of everybody in doing a better cesarean section is required because the patients that we get from periphery have horrible outcome. There is more chances of adhesion, more chances of injury to other organs.
See,
So
that is
training and
why I
strengthening
raised
of
that question that my patient, if I send, it comes to you, will you give a trial? It will depend where that
Yes,
person
ma'am.
is coming from. You don't
Yes,
trust
ma'am.
everybody's scars.
Yes, exactly, ma'am.
Okay.
So
Yeah.
strengthening and training of everybody who's doing a cesarean section should be done so that the decision for VBAC, TOLAC or repeat cesarean section is done in a better way. And third, definitely interpretation of CTG needs to be done by everyone in an accurate way. And fourth, the importance of consent. So these are the four highlights I get from the session.
Thank you. Pratibha ma'am, next, last to you.
On the behalf of Gadhinglas Obstetric and Gynec Society, I would like to say thank you, madam, for making me a part of this webinar. Your Searchlight series are very nice. Today is the 34th series, and out of this 34, so many lectures, webinars attended by me, and those are very nice. Again, even after 20 years of practice, I am very happy to listen. I attended so many webinars, and those are very nice, and that is a really academic feast for us. Today I would like to say all the best for your coming election, as well as take home messages. Everybody said the same, that consent and counseling, these are the very good things for the this VBAC and TOLAC.
You know, at the end, I would like to add something. My take-home message is that we as gynecologists and obstetricians have a role to play, and that is to assist nature, not take over nature. So if something is not going right, before actually jumping in and doing something, we need to find out what is wrong. Why this labor is not progressing, why this woman is not going into labor. Most of the time you will find that there's something wrong. So induction is also not something that you just undertake for fun, because why she is not going to labor is the first thing we need to know. So once we know something is wrong, then we need to take steps to avoid the consequences. So avoid the consequences to the mother and avoid the consequences to the baby, and therefore to ourselves. Because one lost baby and the whole family is on your head, whether it's your fault or it's not your fault. So let us learn to monitor and assess our patients correctly. To assess their obstetrics, their tummy, and also their psyche, whether they are going to be troublemakers for us. And in that case, we need to be extra vigilant. So that would be my take home for today. Thank you so much. Thank you for being here with me
Thank
today.
you, ma'am.
Thank you,
You made the program worthwhile. Thank you, Dr.
Thank you.
Pratibha.
Thank you.
Geeta ma'am couldn't make it, but I think we have discussed almost everything. What's your take on it? What do you all say? Did you enjoy?
Yes,
Yes, ma'am.
Yes, ma'am.
We look forward to more such sessions, ma'am.
Yes, ma'am. Thank you for the
Thank
opportunity.
you. Thank you.
Thank you. Once again, all the best, ma'am.
Thank you, Dr. Pratibha. Please, from your area, get me more votes.
Okay, okay, ma'am.
Thank you so much. And so, good night. We meet
night,
again next
Good
Wednesday.
night, ma'am.
And that day, we are going to talk on genital prolapse. So, one talk will be on diagnosis and classification. The other talk will be on conservative surgeries for prolapse. Conservative surgeries. And then we'll have a panel. Any of you want to join in again? You're welcome. Bye-bye. Good night.
Good night.
Thank you.
Thank you, ma'am.
Thank you.